Hey, good morning. This is Dr. Christy with Natural Living. We are going to do a demonstration this morning on what I do for the difficult patients. It so happens that my employee, Kelly, is one of my hard patients, meaning that her symptomology sounds like it's something that would respond very quickly to chiropractic, but it doesn't. And sometimes when we align everything perfectly, it's not actually what her body wants or needs. And so we have to come at her a little bit differently. And it's important for any of you that are seeing a chiropractor that they know what to do with you if you happen to be one of those difficult patients. So there's 3 things that I do with these patients, kind of my go-to tools that are a little different than your typical chiropractic analysis and even adjustment. So I'm going to bring Kelly in and we're going to lay her on the table and I'm going to first demonstrate muscle testing. So Kelly, come on in. We're going to lay Kelly down, face down on the table. I use muscle testing a lot with patients that have scoliosis. You are never going to get a full correction of a scoliosis on somebody that is done growing. So you can make some pretty cool things happen with children with scoliosis. But once you're looking at somebody that's, say between 18 and 24, you're really just trying to make them more comfortable while still addressing the nerve pinching. And I'm going to look for the nerve involvement using muscle testing. Kinesiology, it goes by that a lot. There's a lot of different techniques that does it. This is specifically the activator analysis for the spine. So I'm going to show you just a few key ones I always check. Kelly, put your arms on your side for me. So with any chiropractic adjustment, we're always first looking to see if their legs are balanced. We just adjusted Kelly, so her legs are going to look fantastic. But rather than coming in here and looking for the tight musculature and the rotation that's typical with a misalignment, when you're talking about a scoliosis patient, there's going to be a ridge of muscle that's going to be high. It's going to be tight, and that's what keeps their spine stable. If we go in and try to correct that, we can actually create problems for the patient. So instead, we do the muscle testing. Kelly, reach your right arm forward for me and bring it back. Now reach your left arm forward for me and bring it back. So specifically with activator analysis, I just checked 4 of the thoracic vertebra that line at the very bottom of her kyphosis curve in her mid-back. So from about here to here, I was able to check to see if there's rotation simply with her using those muscles that come in and attach into those areas. Now reach both arms forward. And we're creeping up. This is T8. Bring it back. And one more I'll demonstrate. Raise your shoulders up to the ceiling. Really squeeze those shoulders up and relax. So that is actually testing the T8, sort of where that bra strap runs, and T7. I'm able to find these misalignments very, very accurately, very specifically using these muscle tests instead of relying solely on my palpation skills. It really helps these patients tremendously. Now, I want to go into the low back. Kelly specifically is difficult because she has very traditional L4 pain. It can radiate sometimes. It can really sit in her SI joints. But when we go in and adjust her L4, she struggles with it. Her body doesn't like L4 to be moved with impulse. So I had to sort of try to figure out how to come at it otherwise. And a very important muscle actually lies on the front of our spine. It's called the psoas muscle, the iliopsoas. It runs from T11, T12, all the way down into our legs, and it does hip flexion. So if you can see me doing the hip flexion, this muscle is what's doing that, is the iliopsoas. Now, when the iliopsoas is tighter on one side versus the other, it will actually create misalignments in the spine, but also in the pelvis. So the way you test for the iliopsoas being tight, I'm going to bring her legs up, and she's going to push her knees into the table, allowing her bum to lift up off the table, and relax. Now, if the iliopsoas is tight on one side or the other, we'll actually see her leg drop. So this morning when we checked her, her leg did drop, drew significantly on the right side. We flipped her over. Roll over for me, please. She keeps her feet up on the table. And we come in here and we actually palpate the psoas. Now this morning we were doing her left. We actually did check and palpate her right as well. But once you get in near the belly button, take a big breath in and let it all the way out. They will find it tender and you will feel that muscle up underneath here being incredibly tight. So using again my activator, big breath in. I would on the mechanoreceptor setting and let it out. Impulse in 4 to 5 times, following that muscle line. Roll back over. After adjusting, okay, the muscle, really we're doing mechanoreceptor reset. We would go back in and do the test again. So we would have her push those knees into the table, bum lifts and relax. And we should see that in fact her legs do not shorten anymore. So that is the psoas muscle. Now, I don't just check psoas on my difficult patients. What I have discovered is that when psoas is tight, and I have a patient who's not holding their adjustments real well, we can get that psoas relaxed and they're holding their adjustments far better. My most recent patient, gosh, I think we see her every other week, every third week, and as soon as we adjusted that psoas, she could not believe the difference. So that is a really, really important adjustment for anybody, not just the difficult patients. Okay, the last thing I want to show you for difficult neck patients. Patients that atlas, for example, needs to be very finely set. That if we go in with an activator even, let alone a manual adjustment, it has a tendency to maybe slip too far, not slip enough, or not stay put. So the still point inducer, Kelly, come on up for me. This is the still point inducer. It's from Upledger. It is a phenomenal tool for helping to set upper cervical, occiput, and atlas, and it does it by using the muscles and allowing these bones again to slip into place on their own. So the way you use this, Kelly, come and lay on the floor for me on your back. You get the patient supine on the floor. I'm going to place it on the nuchal line. The nuchal line is the muscle attachment point on the back of your skull. And each of these little bumps is going to sit right on that nuchal line. She's going to rest her head down. Her arms are completely relaxed. Rest your feet down and legs down. Check after releasing the legs that it's still in place. And we're going to leave her in that position for about 3 minutes. If there's any question as to her handling this adjustment, you can start with 1 minute. But for the most part, we want to be here for at least 3 minutes. We did this morning. Come on up. And with that 3-minute position, using this tool, her atlas actually slipped itself back into place. It's going to hold a lot better this way versus, again, a heavy adjustment from my activator. Or from a manual adjustment. So those are some tricks that I've learned over the years that really, really help those difficult patients. If you're a patient watching this, ask your doctor for information on this. Ask them to try it on you. If you're another fellow chiropractor, use this stuff. It works, and it's for, again, those difficult patients. So thank you. This is Dr. Christy signing out.